Good morning. It's Thursday, October 8th, and we are welcoming you here to The Doctor is In, Ask Dr. Arwady. I'm so happy to be back, Dr. Arwady. I'm Sybil Madison, your Deputy Mayor for Education and Human Services, and this is Dr. Arwady, as you know, your Commissioner for the Chicago Department of Public Health. This is where you can come get your questions answered and hear the latest about COVID-19 in Chicago. You can put those questions in the chat box below, or you can send them using the hashtag AskDrArwady to Facebook or Twitter. We're going to check our social distance. How are we doing?
We're pretty good. We're pretty good. Yeah, we'll make sure.
Which we know that all of you who watch us on a daily basis know how important that physical distance is. I'm going to just turn it over to you, Dr. Arwady, and tell us the latest.
All right, sounds good. First, it's nice to be. We've had a little time period where you haven't been on, but this has been our long-standing conversation here. We are starting a few minutes late today, and that is my fault. But it is my fault because I was getting my flu shot, and so I really hope every one of you has already gotten a flu shot or is making a plan to get a flu shot in the month of October. As we've talked about, we really need everybody, really over the age of 6 months with very few exceptions, to be getting a flu shot every year, and this year is more important than ever. That's actually the tagline. It's a different year is the tagline on one of the flu vaccine campaigns that we're running. And that's because we're not going to be able to tell the difference between flu and COVID by looking at somebody. Your doctor is not going to be able to tell if you have flu or COVID without doing testing. And where we know that there is COVID around this winter, and we know there will also be flu around, we already have had cases of flu diagnosed in Chicago this season, although not very many yet, which is why now is the time to get the flu shot. We do not want to put extra demands on the healthcare system. We don't want to be driving people who have symptoms and don't know if it's flu or COVID, needing to get testing. We don't want you needing to go into your doctor. We especially don't want you getting sick enough that you have to be in the hospital or the ICU. And we do have, thousands of people who get really sick from flu typically every year. The good news is all the things that you're doing to help protect against COVID, the masks, the social distancing, the hand washing, all of this will also help protect against flu, but there's a vaccine for flu too. So please get it this year, even if it's been a while since you've gotten it.
I saw lots of places across the city.
Tons of places, yep. Your doctor's office will have it, pharmacies have it. The Chicago Department of Public Health has free flu shots available. You can go to chicago.gov/flu if you want to see more information about our flu vaccines, and then there's a map on there, and it's ChicagoFluShots.org is also sort of the map finder. But go to chicago.gov/flu. You'll see additional places to get a flu shot. And it's really one of the easiest things that you can do to help protect your health this fall and winter.
Awesome. All right.
Let's
get into the data.
Okay. So let's pull up the dashboard. As a reminder, chicago.gov/coronavirus, right up at the top is your latest data tab. You can also get there by going to chi.gov/COVID-. So where we pull up the main page here, there's a couple things I want to point out. First of all is this current positivity rate. As a reminder, that's our test positivity rate. That's where we take the positive tests and we divide it by all the tests that are done. That is at 4.2%. That is going pretty well because that's the one that we really want to be below 5%. And it took us a while this summer to kind of finally get that back under 5% and staying there. So pleased to see that where it is. We are the second lowest region in the state right now, with low being good when it comes to COVID positivity around that, but keeping an eye on that. And then our tests performed here. This 9,351 right now is our rolling average. This is the graph on the right here. See how this is just going up and up and up and up? Every day right now, we are actually breaking the record for our 7-day rolling average for testing. And this is partly because, as we've been talking about, more testing is becoming available in a lot of settings. There's additional kinds of tests. There's additional testing sites popping up. We're seeing more testing happening on college campuses. We're seeing more testing happening in drive-through and walk-up settings. Obviously, the testing that the city sponsors has continued, and we really drive that to the neighborhoods where it's most needed, but we're really seeing, some real improvements there. But that means that as the number of tests is going up, that does also mean that the number of cases is going to go up. And so we've been having a lot of conversation actually at the health department about how to make sure we're telling this story well in terms of looking at our data, knowing what our case numbers look like sort of in relation to testing, because for the last 6 months, we've been able to assume a relatively stable testing environment where we had a particular goal and we exceeded it, but we've had our hands around sort of the amount of testing that's going on. And frankly, we talked the other week about these new antigen card tests, for example, that never need to go to a laboratory. You can get an on-the-spot result with them. We know that there is increasingly going to be a lot of COVID testing that is probably just not going to get reported to the health department, frankly, because people, even doctors may be doing these tests in their office, and if it's extra paperwork and it's not going through the laboratory, even though it's a requirement, we know people are pretty good about telling us about positive tests, but they don't always go to the trouble, honestly, of reporting negative test results because they've gotten the answer they need for the patient right there.
Right.
But in terms of us understanding sort of what's happening at the city level, it can start to skew our numbers a little bit.
Got it. Because those negative tests wouldn't be in our denominator.
They wouldn't be in our denominator, exactly. So you'd be seeing that positive, that numerator be going up without the denominator going up, which means your cases go up and your percent positivity can go up, but not in a way that is actually reflective of the situation.
Of everything that we
need to know.
Yeah.
That's right. And so where we look at our 7-day rolling average of cases, you'll see here we're at 334, which is up. Like, it's up for sure. But it's up in a way that's fairly consistent with the increase in testing that we've been seeing. And so we've been thinking a little bit about, we may end up introducing actually, there are some metrics that are used in jurisdictions around the country or even around the world. Some of you may know the reproduction number, for example. We're going to be talking some more about some other numbers and ways of looking at the exact same data. It's not that there is anything different in the data or wrong in the data, but it's about making sure that as we are sharing this data, we're putting it in the context of a changing testing scene. So, this outbreak has been nothing but interesting in terms of the epidemiology and really making sure that we are being absolutely transparent and clear about our metrics, what we're following, and our decision making. So I think
just a question about
that.
Sure. So when there was a more stable kind of testing environment, does that mean that we can use kind of trends or rates that we had then to understand or project what might be happening now when testing is kind of booming?
Yeah, so for example, the way we can kind of think about this, there's a few ways. And actually, if people have thoughts on this, you can chime in, because this is an active conversation we're having right now at the health department. So, for example, say we see a 10% rise in our testing, in 1 week, for example. That's a big increase in testing for 1 week. We would actually anticipate our number of positive cases to go up by 10%.
Got it.
So if you had 300 cases, the next week, if everything was exactly the same, you would expect 330 cases. Right. So thinking about sort of that range and probably setting a sort of, here's where the testing has been, what would we predict the positive test to be if we're stable versus if we're heading the wrong way versus if we're heading the right way.
Right.
And
that would help you understand if there's an indication that this is...
That's right, because we do a lot of this behind the scenes, right? Of course, there's a lot of, our epidemiologists do a lot of work to look at the slopes of the curve. There's a lot of science that goes into this, but turning the science into something that really makes sense to people, I care a whole lot about, because I firmly believe that we've all become armchair epidemiologists a little bit here, and especially I think people who tune in here are very interested in the data and really understanding how are we using it to guide decision making. And so maybe we'll talk about the reproductive number a little bit. There's this number R, which you may have heard of, you may not have. R naught is sometimes what's used, like in movies, for example. The epidemiologist will say, we have to figure out what R naught is. And R or R naught or RT, all of these R's are just at the most basic level, it's how many people does one person with COVID transmit to? And so if you have an R or an R naught of 2 to 3, which is what this virus is thought to have, R naught means sort of in the wild. Before you do any masking, before you do any social distancing, if you have one person with COVID and they are exposed, to a room full of people who do not have COVID, 2 to 3 of those people, that's sort of the idea behind it, would get COVID. But to get your outbreak under control, if one person is spreading to 2 people, your outbreak is doubling.
Yes.
If it's spreading to 3 people, it's tripling. Like, that's not good. So the goal is to actually get your R under 1. Yeah. Because 1 means one person is spreading to one person. You have a completely flat outbreak. Yeah. You got to get it under 1.
This is a throwback Thursday conversation. Because when we were in the heat of things,
yes,
we talked a lot about the R naught.
We sure did, exactly. So this is right. So this is this idea that literally bending the curve is getting your R under 1. It means that on average, every person with COVID is transmitting to less than one other person, as in not transmitting.
Right.
And that happens, we will say RT or RE, it just basically means like what's actually happening in the real world. So you really want to keep that sort of under 1. It's not, we've talked about it, but it's not a metric that we have chosen to use here. But we may actually introduce it because it's a good way, you can sort of build testing into it a little bit more. We would have to do some teaching around it, but I like teaching about epidemiology. But it's this thing where, 1 is flat, under 1 is good. You start to get over 1, you start to get into trouble, and you can get into trouble fairly quickly. So it's another way that we sort of track things. Another way that we're thinking about is this concept of how many tests do you have to do to find a positive test? Because the bigger your number gets in terms of the number of tests to do a positive test, the sort of better shape that you're in. And that's related to percent positivity, but it's kind of a different way of talking about it or thinking about it. So if you have comments or questions or thoughts about any of that, feel free to chime in, because we are right now in the middle of this conversation as we're sort of moving into this next phase of the outbreak. We're also starting to prepare toward vaccination. We really want to make sure that we're, following metrics that make sense for where we are in the outbreak.
Okay. We might have to do a Science Saturday.
We might. We might.
All right, let's get to your questions. Beverly Stewart Williams from Facebook. The CDC is saying COVID stays in the air for hours. So how do we not catch this disease, Dr. Arwady?
Oh, what a good question. Okay, so first let's put a little bit of context around the air conversation, actually maybe bringing it back to R, why not? Because we were just talking about it. So not just the CDC, but the WHO, there's been this long conversation for months, really, since COVID broke out about how is it transmitted. And it's been very clear for months and remains clear that the main way that COVID is translated is still by what's called droplets, which is when I am talking or sneezing or, being in the world breathing, droplets are coming out of my mouth, and those tend to be sort of, heavy, and they stay typically within the 6 feet, distance exactly. And that is why most of the transmission that we've seen has been within the 6 feet. It's also a big part of why those masks are important, because they help. They're not 100% protective, but they help a lot in terms of sort of keeping my germs in me and not having them spread with others. So there has been a lot of study around this to basically, first of all, say, is it possible for COVID to what's called aerosolize? Which means, is it possible that in addition to these droplets that are heavy and fall, can you have some amount of COVID that's aerosolized, that's sort of in the air and can be in the air for a longer period of time? And it's been, there have been examples of this that have shown, yes, like that is possible. There were, and we've talked about them on here, there have been a couple of examples, for example, where they were able to detect in a hospital room, someone had been in the hospital bed and they were able to detect a little bit of COVID sort of more than 6 feet away and more than 6 feet away. And for a while they were picking up COVID occasionally in the air, but not really able to replicate it. So it's like, is this actually infectious, or can we just find the RNA? But there have definitely been some examples, especially in these so-called super spreader events, we think, where, inside in sort of poorly ventilated areas, especially if people aren't masking and aren't social distancing, that there's been just a lot of spread. And it's been hard to completely tease out how much is in the air versus sort of how much is droplets and who's not washing their hands. So I think, it's clear to me, sort of looking at the evidence at this point, that absolutely COVID can be aerosolized and it can be in the air, but the main way that COVID is spread and the way that it behaves in an epidemiologic way is still much more like the viruses that spread more in this sort of person-to-person interaction way. And if we take it back to R, this idea of something like measles, and sorry, one other thing is that the word airborne has a lot of different terms. Yes. So airborne in the way that like normal people talk about airborne just means it's in the air. That sounds easy, right? But actually, airborne from an infection control standpoint has a very different meaning because it implies sort of a different
threshold.
It's a different threshold, and particularly in like hospital and healthcare type settings where you have a lot of people who have underlying conditions, almost by definition, because they're in the hospital, and a lot of sick people there. There's a lot of attention to air handling. So airborne has a different meaning in terms of infection control and the personal protective equipment. But measles has an R of like 16 to 18.
Wow.
So if you are in the room with somebody who has measles, even like if that person's left the room and you're in there 2 hours later, there's a very good chance that you're going to get the measles if you've not been vaccinated. And we see that. I worked on an outbreak here in Cook County where virtually it was in the daycare, and we don't start vaccinating until age 1 for measles. Like almost every kid under age 1 got the measles. Like that's just, it's very, very transmissible. Chickenpox is transmissible in the air, tuberculosis, some of the, truly sort of airborne.
And so COVID is not
there. COVID is not, and when we look at sort of how that behavior looks like, you wouldn't think that, social distancing does not make a difference for measles, like not a big difference, right? Yeah. A mask of the type that we're talking about would not be thought to make a big difference in measles. Whereas for something like influenza, which is really thought to be fully droplet, I think people are actually theorizing that if we looked really hard, we might find examples where influenza also maybe can be aerosolized and you can find it. But it doesn't have, it's got these R's that are more in the sort of 1, 2, 3 range, as opposed to the much, much higher ones where airborne is the sort of the primary means of transmission. So what all of this kind of means to me, back to sort of the question a little bit.
In CAPS,
yes,
Beverly asked, how do we not catch this disease?
How do we not catch this disease? So in CAPS, the way that we do not catch this disease, first and foremost, is to continue to do the things that we have been doing all along. There have been some very reassuring studies that have shown that, for example, even in hospital settings, we talked about one, I think, last week, where they went back even in like before there was a lot of masking even going on, and there were infected healthcare workers like within 6 feet. People weren't wearing masks. This wasn't, very little transmission sort of even kind of in that setting. And we've seen very clearly, and even here in Chicago, the biggest thing that has managed to keep this outbreak under control are these individual level behaviors. Like that's very clear when you look at the models and everything else. When you keep your distance, when you wear your mask, when you wash your hands, when you protect vulnerable folks, those remain sort of the most important pieces. Yeah. I think on top of that, there is also the possibility to think about, air handling, but it is not the top thing, and it's kind of like testing for me. Like they're here and they're sort of additive, but they're not the most important thing. And especially, unless you're in a sort of hospital type, a setting where there's a lot of known COVID exposure, you've not seen recommendations to change air handling systems or overhaul, major things about the way that we do things here. There are definitely recommendations around, and if you're interested, the CDC website has more details about this. Sure, having, windows open, cracking your window in the car, having your window open at home. If you've got fans, blowing them outside inside to help move air out. You can, if people are using air filters at home, you can buy an air filter that can sit, in your room. And there's some filter recommendations around that. Those are additive, and I think they can be helpful, but they are not the primary thing that I want folks thinking about or worrying about. And my worry is that people kind of like testing. They think, oh, I've been tested, I don't need to wear a mask, I don't need to social distance, or like I bought an air filter, I don't need to worry about this. No, masking, social distancing,
comes down to our individual behaviors and choices.
Comes down to our individual behaviors and choices. But I think people are definitely looking at ventilation and making sure that we've done the appropriate things, and that has been happening for months. That didn't change sort of with CDC. There's recommendations that have made for all the large buildings, et cetera. Just thinking about how are we increasing airflow. It's not a time to be putting some of the energy. During normal times, we're pretty interested in maybe not bringing in as much outdoor air, like in the winter, for example. That's like the opposite of what's happening now, related to sort of larger buildings and systems. But for you, please keep doing the things that work, and especially if you're inside, right? Like as we're moving inside for the fall and winter, it's going to be especially important keeping that distance, washing your hands, et cetera.
Yep. Okay. Ryan McMahon from Facebook. Do we know Chicago's current R naught?
We do. So it's funny, just last night I was on there's a lot of ways that you could calculate this. It is under 1 right now. That is what I will say. It's right around 1, but it's just under 1.
Okay.
And we are working on deciding exactly how we're gonna do that calculation. But we're hanging out right at just under 1.
That's good.
It is good.
Okay. Donna Brown from Facebook. How long will this COVID last? Your prediction.
All right. It's crystal ball day. So I do not think we are ever going to eradicate COVID, just to start with that. I don't think that this is going to be like smallpox, that we are able to completely get rid of it, unless by some miracle, one of these vaccines turns out to be like 100% protective, and there's a very easy way to, to administer it. But I expect that COVID at some level is going to be a disease that is with us. However, what will get us past COVID in terms of the huge disruption that we have seen to everybody's life and the very serious time period here, I do think is dependent on the vaccine, and specifically when we are able to have enough people vaccinated to get to what we call herd immunity. And herd immunity is this idea.
That's a term that we heard a lot about.
It is.
Right?
It
During
is.
stay at home.
We sure did.
Yeah.
It's the herd immunity is this idea that enough people have immunity to the virus that if somebody is infected, there's sort of nowhere for it to spread because there's not enough people around who are not immune. So we have herd immunity broadly to measles because we have very high rates of measles vaccination here. And so it is unusual, we get cases of measles and we do a lot of contact tracing and case investigation every time we have a case of measles, but we don't see widespread measles outbreaks here because we are at herd immunity. Now, when that is going to happen and exactly what the vaccine needs to look like to get to that point remains some open questions. So remember, we're still in the phase 3 trials for these vaccines. We don't know yet how protective these vaccines will be.
Right.
They will not be.
There hasn't been enough time to have passed for us to understand how long the immunity lasts.
That's precisely right. We don't know how long the immunity lasts, and we don't know how protective the vaccine will be. It has to be at least 50% protective or they won't approve it. Ideally, it'll be 80%, 90%, but there is no such thing as 100% entirely protective vaccine. And first one out of the gate, to be honest, we would be very happy to have a vaccine that cut cases by a lot and especially help people not get hospitalized and die, right?
Yes.
That would be a very successful vaccine. Like a flu vaccine is not 100% protective against flu, but it significantly drops the cases we see. It has major impacts in terms of hospitalizations and death.
Reduces
the severity. And so, and then how long the vaccine will last is very much an open question. So I expect if we want to put some numbers on it, I do not think that we are going to have a vaccine, physically here in Chicago in the year 2020. Let me just say that clearly. I expect probably if the vaccine trials go well, right? Like they are still in process, and it is possible that some of these vaccine trials will not work. We don't know for sure which will and will not. But my guess is that based on the early data, that we will start to have an effective vaccine, probably get approved around the end of the year, might be my guess, or possibly early next year. I think we might see our first vaccine doses here in Chicago, maybe late in the first quarter. If I had to guess, of 2021, it could be a little earlier, it could be a little later, but that'll be a pretty limited number. The whole world's gonna be looking for this vaccine. So this is gonna be healthcare workers, there will be some prioritization. I think it'll be more in the second quarter and into the third quarter that we start to see much more vaccine. As it rolls out, there will also be additional studies that are done. So children will not be in the first round of vaccination for sure. I don't think we'll be vaccinating children here in Chicago likely until the summer, if I really had to guess. And then it will be a series of sort of what does production look like? How effective are these vaccines? How many are coming? What is the distribution like? Like it's a huge logistics piece, and my team's been doing a lot of work on that. 2021 to me is going to be about rolling out this vaccine while we continue masking and social distancing, and it's going to be this complicated series where we're still not going to be fully able to go back to normal because everybody's not going to be able to get the vaccine at once. It's going to be this process.
So as a city, though, is it safe to say that our goal would be to reach herd immunity?
Yes, our
and
goal
that's something that we could actually...
Our goal is to reach herd immunity. I think we can do it. I think it will happen. It will not happen without a vaccine. Let me be clear about that. At least not in any safe way that would not lead to huge amounts of sickness and death. But we, yes, I think we'll get there. I think, my guess is by this time next year, we'll be in generally a good place from COVID, assuming the vaccines work, assuming people take the vaccine, assuming that we are able to broadly keep things in control, kind of in the meantime. And so I know that feels like a really long time, but on the other hand, like, let me tell you, I love getting the vaccine updates because I'm like, that means actual progress and us getting to the other side of this. So I do feel optimistic about where we are and where we're heading. I don't know what this winter is going to look like, just to be perfectly frank. And
no one does.
No one does. We've never had COVID in this time of year, like ever. And so it's going to be interesting. I feel, we've done a lot of preparation for whatever might come, but I cannot say strongly enough that the individual behaviors people make every day are what drive our success or failure. And I think some of the reason we've been able to stay broadly in control here in Chicago compared to many places around us are that people have broadly been protecting themselves and protecting their neighbors. Yeah. So
that's a great question, Donna, because people talk about COVID fatigue.
Yeah.
So it is kind of helpful to wrap our heads around the fact that the choices we're making today, we have to continue to make.
That's right.
For some time.
That's right. That's right. And there will be an opening. Like, it's going to be sort of just like think back to February and March and how different that conversation feels than the conversation we're having now. I actually think the conversation we're having now is going to be just as different as the conversation we're having next February and March. Like, there have been really different phases in terms of what the focus is, what the concern is, what we need to be working on. I promise I've got teams across the health department focused on all of these areas and planning for all eventualities. But we just don't know the full answers yet.
Yeah, it's been about adaptation.
Adaptation, being nimble. I just told my team this morning, we had our all staff team and people were asking very good questions and we've had to change a lot of our operations and I said, this is for everybody. This has been an exercise in some ways in adaptability and change and resilience. Yep. Jinx.
Okay, Maxine Terry, at Drive Up COVID test sites, do you do the test yourself?
It depends on what kind of test it is. So there are drive-up test sites that are the deeper nasal swab. That might, particularly at a hospital, that might be what you get, in which case you sit in your car and somebody in PPE, does it for you. But there are increasingly many test sites where people are able to do the test themselves. And partly that's because the technology's gotten better, and very often we're not needing to do those deep nose swabs anymore. You can do a nose swab just in the front of your nose, or you can do the mouth swab. So at the sites that the city sponsors, for example, with CORE, those you do yourself. They give you a kit and you swab, and instructions, you swab inside your mouth, you put the swab stick into the little tube, you close up the tube, you put it in the bag, you put the bag out. That's what's done.
Yep. Here's a great question from Sandy Rusinski Livingston. If someone has tested positive, but they are feeling well, should they quarantine for 14 days? And then, does any agency check in on them to see that they are quarantining?
All right, good question. So when someone has tested positive for COVID, no matter what their political position may be in this country, they need to isolate. Isolate's just the word we use for someone who's sick. Quarantine is technically the word we use for someone who is well but exposed. And they actually need to isolate for 10 days. And it can be a little confusing sometimes because it's 10 days that you need to isolate because you can spread for 10 days. And the last 3 days you need to be better. So no more fevers, no more issues. 10 days is the least amount of time that you must isolate if you have a positive COVID test, from the time your symptoms start and or you had a positive test. The health department calls and follows up on every single positive case of COVID that is diagnosed in a Chicago resident. Assuming it is reported to us, which it needs to be by law, we receive that information from the lab, typically, that is doing it. We get it electronically. It's all very secure. And then our case investigators reach out and talk to everybody who is infected with COVID, or at least attempt to. This is where picking up the phone.
Everybody who picks up the phone,
and we try multiple times, and we have ways of reaching out. But we do start a case investigation and attempt to finish a case investigation on everybody diagnosed with COVID. And we are having those conversations with people, ideally as soon as possible after they are diagnosed, to make sure they are isolating, to see what they may need to be able to isolate safely. Right. Are people needing help with housing? Are people needing help with food? Are people needing help with, notes for jobs or childcare? Do they need to be connected to medical care? We want to be very sure that anybody who's tested positive, especially if they did it at a drive-through site, is connected to medical care. And then...
So you are the agency that checks in.
The health department is the agency that checks in. And then we have sort of, depending a little bit on the situation, we will follow, sometimes we'll just call people back repeatedly. Sometimes we will enroll people sort of in a texting check-in. Sometimes if people are generally secured away, we may not talk to them again. But we go on, and then our contact tracers, including the community-based contact tracers, are reaching out again in a private way that never even says the name of the case. Okay, your privacy is kept. We don't share your information with your employer. We don't share your information with anybody. Any contact that you tell us about, we call and say, we don't say who, we say you may have been exposed to COVID, here's what we need you to do. So that is the checking in that happens. It is why even President Trump needs to isolate for 10 days after his test, and at least the last 3 days of which he needs to be symptom-free.
I will go to the next question. Maggie K9 from Facebook.
Chicago Department of Public Health doesn't check on him, though.
In addition to the flu shot, which I got, very good, Maggie, my doctor also recommended vitamin D and pre and probiotics. Can you talk more about that?
Sure. So, couple things. So, I take care of patients here in Chicago, and most of Chicago is vitamin D deficient. I will just tell you that, because we are in a northern latitude city and we don't spend a whole lot of time outdoors by and large. And so I pretty routinely will check my patients for vitamin D deficiency, and then I recommend vitamin D if they are deficient, and many are. There's been some studies that have suggested possible correlations between sort of COVID and lower vitamin D or higher vitamin D. I've not seen anything, it's not like vitamin D cures COVID. Let me be clear about that. It's not that vitamin D has been shown to be, a specific treatment for COVID, but vitamin D does modulate the immune system in some ways. And so I think, there's certainly not a problem with taking vitamin D as long as somebody is taking a appropriate amount of it. I don't want anybody going and thinking they should be taking bottles full of vitamin D. But most of Chicago is vitamin D deficient. So a multivitamin, et cetera, is fine, certainly if a doctor is recommending it. Similarly, pre and probiotics, there's nothing specific about COVID for those. Perhaps, I don't know if you, this person wasn't sick, right? This was just a proactive kind of thing.
Seems like it was.
Yeah.
proactive.
So there are people, especially if you have GI systems or symptoms or issues, or you've had to take antibiotics or anything like that, they can help make sure that you have healthy bacteria in your gut. But I don't recommend either of these personally, sort of proactively in a preventive kind of way. But if your doctor recommends it, that's because your doctor knows your history, your lab work, et cetera. And I would, as always, recommend that you follow the advice from your individual doctor. That is always my advice to everybody for any question related to drugs or supplements. So good job getting your flu shot. Good job seeing your doctor when you got your flu shot, because that means it lets your doctor check in and make recommendations to help keep you healthy this winter.
Right. And, a lot of our doctor offices are back open for business.
Absolutely.
So, okay, here's the last question that we have time for from Margaret Quinn on Facebook. If most cases in Chicago are coming from private gatherings, family transmission, and we've talked a lot about how it's household spread now, right? Why are travel restrictions still relevant?
Oh, okay. So
I knew you would appreciate this question.
I do appreciate this question. So I think Sybil's laughing because some of the data that I showed at our internal meeting this last weekend was we were looking at a particular sort of cluster of cases, and we had found that, like, in one of the areas of the city that we were looking at, more than a third of the people had traveled out of state in the 14 days prior to when they were diagnosed with COVID. Not all necessarily to places that had a quarantine requirement on, and people were actually quarantining in some cases after they had returned from places. But nevertheless, travel itself is clearly a risk factor for COVID, and travel to these states where COVID is in very poor control is very clearly a risk factor. I don't know how closely people have been paying attention to what's happening in Wisconsin in particular, but Wisconsin's outbreak right now is worse, like significantly worse than we were at the worst of our outbreak in like April, May. And they have turned their state fairgrounds. They are opening their state fairgrounds into a field hospital, alternative care facility, like, we had to do here. And, I've got friends up there and doctor friends, and they are seeing full hospitals, and they are seeing deaths surging, and they've really not done very much in the way of restricting, some of the things that can help keep that spread down. And it is quite political, as the mayor actually said in her comments yesterday. But it is not a good idea to go to Wisconsin right now. I just want to be clear with you. And I don't have anything against Wisconsin, but there are, we're talking about percent positivity. I'm happy that we're at a 4% positivity. Wisconsin's had like a 20% positivity in the last week. And that, in a setting where you've got bars open and schools open and people not wearing masks and hospitals filling up, is really dangerous, just gonna be honest. And so I actually, the travel order that we've done is it's probably been the biggest administrative burden for the health department of anything that we have done to date here, because it's brought a lot of questions, it's brought a lot of requests, a lot of clarifications, but I think it has been very effective in terms of making people think, sort of recognize that, we are not a bubble here. When Wisconsin and Indiana and Iowa and Missouri, or even downstate Illinois, are surging, there's nothing that kind of keeps that from moving. We're not New Zealand. We're not an island.
Right.
And so I think it's one of the best things we've done, honestly, even though it's been hard.
It actually is a national model. Right?
It is a national model. It is a national model. And the thing is, it's, you can travel. If people need to travel, they can travel, but you have to quarantine when you come back, because I don't want people, unnecessarily spreading it here. And it's, it's something that is being done really quite broadly across the country at this point. And I know it's hard for people. My cousin is getting married and was supposed to go to Wisconsin on her honeymoon, okay? She's not going to Wisconsin on her honeymoon. And that's hard, but it is the right thing to do from a COVID perspective right now. And we will keep it in place for as long as we need to.
All right. I think we have just enough time for some good news.
All right.
We still do that, right?
We do still do some good news. Anything you want to?
Well, I'll just throw in here that the Chicago Park District has been having programs this fall, in-person programs as well as virtual programs, and they're soon to be wrapping up their Fall 1 session, and Fall 2 session is around the corner. So just wanted to raise that. And then I wanted to say, getting ready for vaccines, we do have the Shy COVID Coach. And I think that's something that people should look into and sign up for if you haven't, because that just kind of gets you ready for any kind of registration process that's coming up around vaccines.
Yeah, exactly. And you can find that, you can find the link there on chicago.gov/coronavirus. In addition to being a way to follow your symptoms, check in with the health department, get advice about what to do in quarantine, et cetera, it is a way for some pre-registration for vaccine. It does not let you jump the line, let me be very clear about that, but it's a way that we can alert you when vaccines are available, what's near your home, we can link you to testing, et cetera. So yeah, that's a good thing folks can do for sure. I also wanted to just share, so first of all, on Tuesday, we're going to have a special guest, Sandra Laney from the Walder Foundation. And the Walder Foundation has been doing a number of things here in the Chicago area related to COVID. One that I'm really excited about and that she's going to be talking about on Tuesday is they've been, they worked with the Chicago Department of Public Health, the Cook County Department of Public Health to say what academic research can we help support to answer questions that are important for COVID public health in Chicago. So questions like, why does one zip code have higher rates than another? What works in terms of getting messaging out? What can we think about with some of this wastewater that I've been interested in? And they funded a number of academic partners here in Chicago to help answer questions that we really are interested in having local answers for. So we're really excited about that. And they also, it's related to the other kind of good news here was both the Walder Foundation and Arts Illinois Illinois, try again. Arts Alliance Illinois have put some more money up for art venues that, of course, have been having such a rough time of it, where all of our traditional in-person entertainment just is broadly not happening right now. And so they are bringing some financial relief to 120 venues across Chicago. And there are eligibility criteria and applications at chicago.gov/artsvenuerelief. You got to get your application in by October 23rd, and then there will be a lottery system for qualified applicants. So if you know an arts venue here in Chicago, obviously encourage them to look out for that. So, I always like seeing where organizations are standing up and thinking about how to kind of help communities in different and creative ways. So.
Yeah. All right. Well, I think that's it for today. Like you said, you'll be back on Tuesday with a special guest.
Thank you for coming back. It was fun talking with you today.
I know. It was great to be your sidekick again.
Absolutely.
So until then, we all need to make those choices that we know will make a difference, continue to make a difference here in Chicago. So be safe.
Yep. Be safe, Chicago. We'll see you next Tuesday.